my name is Dr. Oliver Price, and I'm an associate professor within the School of Biomedical Sciences, and I specialise in respiratory physiology and exercise medicine. As a group, broadly, we focus and specialise to understand exertional breathlessness and how that can contribute to exercise limitation and physical inactivity. We typically focus on two subgroups of individuals. Firstly, we encounter individuals who are otherwise healthy, young, active individuals, but they report exercise-induced respiratory symptoms. At the other end of the spectrum, we have individuals with pre-existing Airways disease. These individuals have profound ventilatory limitation, and as a result of that, they tend to lead sedentary lifestyles, so they tend to avoid activity or situations that may provoke their symptoms, which is understandable. But the knock-on effect of that is over time they tend to undertake less and less activity. So it's this sort of negative cycle whereby they become more and more sedentary over time. And in the same way, if you or I didn't go to the gym, or we didn't go for a run or exercise or lead an active lifestyle, we become physically deconditioned and physically unfit. What sparked my interest in this area as a physiologist interested in exercise is that I always wanted to use my knowledge and apply my research and have a clinical application. From my perspective, that perception of breathing difficulty or struggling to catch your breath is probably one of the most sort of frightening symptoms or experiences you can have. Something that surprises people about my research is, again, thinking about the two cohorts that we focus on, the particularly high incidence of airway dysfunction within young athletic individuals, with some studies indicating up to 1 in 5 elite level athletes will have evidence of exercise-induced asthma. Likewise, we think about chronic Airways disease patients. Typically people think of that as just a condition affecting the lungs or the respiratory system, whereas research conducted over the past 5 to 10 years has made it clear that actually it's a multi-system disease. A high proportion of patients will have evidence of skeletal muscle dysfunction or wasting, impaired bone health, impaired cardiorespiratory fitness. And from a psychological point of view as well, they'll often have heightened anxiety and depression scores. So in terms of management, we need to be thinking it's not just a condition associated with impaired lung function, it's also we need a holistic approach to try and address all of the extrapulmonary comorbidities as well. So in terms of the change that we hope to see as a result of our work, in the medium to long term, what we're hoping to achieve is that the recognition that patients, alongside pharmacological intervention, also non-pharmacological interventions such as exercise, diet, physical activity promotion are equally important as adjunct therapies. What we're trying to achieve is that healthcare professionals, clinicians feel comfortable in clinic, in routine review, prescribing adjunct therapies, lifestyle interventions to improve clinical and patient-reported outcomes. What I enjoy and the best thing about the research is seeing the translation into the lives of patients, for patients who are otherwise inactive, and it's having a major impact in terms of their overall quality of life, receiving that feedback from patients to say that this more tailored, personalised approach to lifestyle interventions has had a major impact.